Cool, thank you. Well, my name's Shannon Johnson. I am a patient care manager here at UK Healthcare for one of our trauma surgical universal care units. I also kind of have a dual role. I work with our orthopedic trauma team as their nursing dyad partner. So I've worked with them a lot over the years and still kind of help them with process and quality improvement, and kind of both of these roles have merged into, me working a lot on optimal inpatient care for geriatric trauma and fragility fracture patients. So, I know the theme of today is really fall and osteoporosis prevention, but I'm going to talk a little bit more about how we manage the care of our fall victims in the inpatient hospital setting, and how we best manage recovery from the fall and secondary fall and injury prevention. All right. So before I begin, I'm going to note, anytime I'm saying the word geriatric, I'm referring to persons that are 65 years of age and older. And no secret to you all that are here, but traumatic injury in a geriatric patient can result in pretty devastating effects. Only a small percentage of these patients do return to independent ambulation and living, and many can remain bedridden and in nursing homes. And additionally, they have a higher one-year mortality rates and healthcare costs. Geriatric population is increasing nationwide, which is leading to an increase in our geriatric trauma patients. I know we're feeling that here at UK. I'm sure others are seeing that as well. In Kentucky, this is especially true because we see more deaths related to traumatic injury than more falls on average in geriatric patients than in the US as a whole. I had our registrars pull a little data for us too, and last year, 77% of our geriatric trauma patients were admitted following a fall. So that's definitely our biggest mechanism of injury for these folks. And another piece about Kentucky, we do have the third most unhealthy geriatric patient population in the country, so that makes recovery from traumatic injury challenging. So given these considerations for our geriatric trauma population in Kentucky, our teams here wanted to further work towards improving outcomes and providing best practice care for these patients. The American College of Surgeons published a best practice guideline for geriatric trauma care in November of 2023. And so since then, we've developed this pathway for geriatric trauma care. And just to kind of briefly take you through the algorithm, you have a patient who's 65 or older, they present to the ED with an injury. They're either admitted to our hospital medicine fragility fracture team with orthopedic trauma consult if they just have isolated hip fractures due to the high incidence of frailty associated with those injuries, or anyone else typically goes to our trauma service. Still working to operationalize our clinical frailty scale screening, but that's something that it's kind of next on our list. So we still wanted to include it in our algorithm because it is important to kind of help determine level of care and some of the care pathways. But the majority of these other items really apply to our best practice for all geriatric trauma patients. So once we have the patient, they're admitted to their primary service. They'll activate our geriatric trauma order panel, which is going to include a PTOT consult, nutrition consultation. It activates nursing orders for education on fall prevention and osteoporosis, and a nursing bundle of delirium precautions. In addition, the provider, is encouraged to initiate advanced care planning, and our pharmacy team will do a medication reconciliation. Beyond that general geriatric trauma order panel, if the patient has sustained an orthopedic injury, there is an additional order panel that is activated for our fragility fractures. And further still, if it's a hip fracture, there's the orthopedic team actually orders an additional order panel for that. So we'll go through a few of those so you can kind of see what we're doing for these patients. I realized some of that was hard to see. And so here's kind of a sample of what our geriatric trauma order panel looks like. So most of those items are pre-checked. We have some options for palliative care or hospital medicine consultation as needed. And then onto those fragility fracture orders, some of the things in here, if orthopedics hasn't already seen the patient, certainly an opportunity to consult them. We typically consult our pre-op anesthesia team to evaluate these patients for medical optimization for surgery in the event that operative intervention is needed. So as not to further delay surgery. You know, some injuries may be non-op, but certainly our lower extremity ones for the most part do require operative intervention. That inpatient consult to nephrology is actually to consult our bone mineral metabolism service. They begin an inpatient workup. They'll arrange for lab work, which you can see some of them here. Some will continue on the next slide. They provide education for these patients. If medications indicated, they get them started. They also get outpatient follow-up with our bone mineral density service. We've worked on, this has been in place maybe about a little over 6 months now, but we have one of the nurse practitioners who works with our bone mineral service now was one of our orthopedic nurse practitioners first. So we've actually partnered in our orthopedic clinic. We have for our operative patients a post-op clinic. It's every Monday, and it's a dual ortho post-op wound check and bone health visit. So they get it's one follow-up, which is a lot easier than having to come back for multiple visits, but they're getting both things addressed, which I think has been really neat. And we'll talk a little bit later. We've worked with some of the rehab facilities to make sure they get back for these appointments and everything like that. And then certainly DEXA scanning if there's follow-up appointments. We'll arrange that if we can. And so here's just kind of the continuation of some of that lab work. In addition, our calcium and vitamin D supplementation options, pending that vitamin D results, the provider will select which dose they need. The final order panel that I just wanted to show you all, this is for our geriatric hip fractures. Our orthopedic team will order this. They consult our pain anesthesia team for fascial block administration. This, allows for lower opiate requirements for pain management, which is really important for our older folks. We've worked on that process for several years. This last year, we've been in a really good flow, really good partnership with anesthesia or PACU teams, so we have adequate monitoring post-procedure for these patients, and we can actually perform them 24/7 now. So that's been a huge win for our patients. They're also getting an admission dose of TXA unless contraindicated, and they get an additional dose of that intra-op. And then there's imaging options too, if there's other imaging the orthopedic team needs. And again, these patients are primarily admitted to our hospital medicine fragility fracture service. This next slide kind of showcases something we started specifically with that fragility fracture service because it was our hip fracture patients. We established kind of a preferred provider network of acute and subacute rehab facilities to help kind of the transition from our acute care into that rehab setting. We created these partnerships, so that we could provide patients and families with quality rehab facility options. I mean, they don't plan on any of this. They didn't have time to pick out their rehab facility before they fell and broke their hip and came in. And so we thought it would be really beneficial to give them some insight on, facilities we have good partnerships with. We have good open lines of communication. We know they can provide the therapy, meet the therapy needs of these patients, facilitate follow-up appointments with us, and are just responsive to our case management team during the placement process. So we trialed that with our HMFF team. And if you can see from when we kind of started our observed to expected length of stay index, how much we've decreased that. And that's been just a huge win for those patients as well. So that first piece is just kind of an outline of stuff we've worked on for several years.
You're right. I wasn't doubting you, BB, but I wonder if
to be a part of in my time here. But I wanted to jump really the big part of my talk, and it all contributes to the good things we do for our patients. But the big part of my talk is in our inpatient nursing care portion of our work. This is something that I focused on over the last year as part of my DNP project, and it's been really beneficial to our patients and our staff. And so that's going to be the rest of this presentation kind of focuses on that. But I referenced earlier our ACS best practice guidelines in geriatric trauma care, and some of the key points in their hospital care section, they highlighted a geriatric friendly hospital environment. And given the unique impact that nursing care has on the geriatric friendly hospital environment, that's where I've focused most of my efforts. So the goal was really to operationalize and evaluate the impact of admitting geriatric trauma patients to a dedicated unit. The way I was measuring that impact, I aimed to reduce length of stay, but also wanted to see if we could reduce inpatient complications or improve the discharge disposition for these patients. Geriatric focused units in the literature and other disciplines did show that you could achieve a decrease in length of stay, decreases in mortality, delirium, pressure injuries, and some improvement in discharge disposition and long-term physical and cognitive function. And I say in other disciplines because there hasn't really been any literature yet that focuses on geriatric trauma units specifically. It's recommended, but haven't really seen it in practice yet. So that's what we aim to do here. So I designed this study as a quality improvement project, aiming to optimize geriatric trauma patient care by cohorting the vast majority of our geriatric trauma patients to the 9200 universal unit that I manage within our trauma surgical service line here at UK Healthcare. We were collecting retrospective data from 3 groups of patients in 2 different time periods. With no intentional randomization of patients, although you could say that assignment sometimes is a randomized process, but nothing we could really speak to from a data standpoint. So the 3 groups that we compared were the patients that were admitted to our unit last fall, so September 1st of 2024 through November 30th. That was our intervention group. There was a collection of patients that didn't get admitted to our unit just due to capacity constraints. And so they were kind of sprinkled out amongst 4 other universal care units within our trauma surgical service line. So, we still had the vast majority, but if you looked at those 4 units kind of combined, it gave us a pretty good compare group in the same time period. So we used that as a control group. And then we compared as well geriatric trauma patients from the year prior when they were just being admitted to any of our 5 units, not more to 1 or more than any of them. So those were our 2 control groups we were able to look at. Inclusion criteria for the study were patients that were 65 and older and admitted to the hospital with a traumatic mechanism of injury. But in addition, they had to be admitted to one of our 5 trauma surgical universal units. Exclusion criteria included patients that weren't admitted to the hospital, or maybe they transferred to our Good Samaritan hospital partners. If they initially went to the intensive care unit and not a universal care unit, we kind of figured that might skew our data, so we omitted those patients. If they had no injury severity score, so scored 0, they had no injury, we didn't include those patients. And then if they were admitted to a different unit, as we already.
So you just feel really tired, right?
So to prepare our team, we discussed this initiative in our staff meetings during the last summer, and provided training modules and Zoom sessions with the dementia-friendly Lexington group. This allowed our unit to. It was really important to kind of help support our staff in the care of these patients, and kind of some of the different things that we wanted to be ready for to provide best practice care to them. So here's our group getting our recognition and stuff like that.
Shannon?
Yes.
So again, I'll be making a few trips out.
We'd like to ask someone to please mute their phone. They're cutting in. Someone is connected by phone. If you could please mute.
There's some traffic coming in, yes. Also, if I may, if you need to step away from your PC, from the video for a second, for whatever reason, for whatever engagement, it might be a good idea to turn off the video. Thank you very much.
Thank you. I'm sorry, Shannon, to interrupt you, but it was talking over top of you.
Yeah, no, thank you very much. Okay, so we'll move on. So this is kind of the intervention piece. Starting September 1st, we officially launched our geriatric trauma unit initiative. We equipped each patient room with a dedicated rolling walker and bedside commode to ensure that we could promote safe mobility for these patients that are already at risk. Each room was also provided a laminated delirium checklist with an attached dry erase marker. We hung that on the computers just to provide guidance to the nurses, as they're doing their first shift delirium rounds, to kind of check off things in the morning and the evening as they come in. It wasn't like a mandate that we wanted them to turn into us. We truly wanted it to be kind of an aid. So those are some of the items we used. And our main instrument for data collection was our UK Healthcare Trauma Registry database. The chart abstraction is maintained at 60 to 90 days from patient discharge. And all patients are given a unique trauma ID number, so that helped to protect patient identity during our data collection and analysis. This database includes all admitted traumatically injured patients, as well as any tier 1 or tier 2 trauma activated patients that present. And some of those trauma activations occur based on criteria from the emergency department presentation, but then they may or may not actually need to be admitted or even traumatically injured. So we had some additional exclusion criteria that applied to those patients. But the data that was provided in the reports included demographic data, patient age, gender, that injury severity score, procedure codes, or post-ED unit disposition. And then our outcome measures of interest were our length of stay in days, inpatient complication incidents from 5 categories, such as an unplanned ICU admission, delirium, falls, hospital-acquired pressure injury, or venous thromboembolism. And then our discharge disposition level of care ranging from home, all the way to hospice or the morgue. So those were the things we looked at. So we got 2 reports from our trauma registry from the 2 different time periods we were looking at. We did have to do some additional data abstraction. If their post-ED disposition was listed as a procedural area, then we did have to look these patients up to determine their post-procedure unit admission location. And then once we had all of our information and utilized our exclusion criteria, we created the 2 control groups and intervention groups shown here. Our 2023 control group had a final sample of 271 patients. And then you can see for 2024, our geriatric unit admitted 157, while all our other trauma units collectively admitted 128 patients. So for our data analysis, we use SPSS as our primary tool. Descriptive statistics for the demographic parameters. We utilize means, standard deviations, and frequency distributions. And then for comparison between the 3 groups, we used an analysis of variance and cross-tabulation by squared testing. Outcomes parameters were also analyzed via SPSS. We did have to do some additional analysis with another statistical platform that our statisticians helped me out with. And that was so that we could do a multiple linear regression to assess for the differences in the demographic data between our groups. And so this table showcases our descriptive statistics and initial comparative analyses that were calculated. Some of the findings included that our 2024 intervention group sample, and this is the one that ended up on our unit, was significantly older than both control groups. So that was kind of an interesting finding. In addition, the incidence of operative intervention was found to have a significant difference between groups as well. Our control group in 2024 had a much lower incidence than the patients that ended up on our unit, and the year before when we had patients kind of going everywhere. The only other statistically significant difference was found in the discharge disposition distribution. So no statistically significant difference found in length of stay between groups. But when we did that multiple linear regression, it revealed that injury severity score and incidence of OR were both found to have a significant effect on length of stay. Which it makes sense, for every 5-point increase in ISS, there was an associated 8% increase in length of stay. And those with any visit to the OR had an associated 55% increase in length of stay. I think it's pretty significant, but also makes sense. So discharge disposition, as we said, that did vary between groups. That 2024 intervention group, which was on our geriatric trauma unit, had a higher percentage of patients that discharged to subacute rehab, and the hospice or ward than the control groups. So just something to note there. But and looking at complication rates, no statistically significant differences. However, our 2024 intervention group had a higher percentage of unplanned ICU admissions, but also the lowest percentage of delirium. So another interesting finding. So major takeaways from this data analysis for our intervention group. This group had an older patient population and more operative interventions than that 2024 control group. Now, we did not see any significant difference in our length of stay, but knowing that operative intervention should increase the length of stay, we still found that to be kind of a win, that even though maybe they should have had an increase, they didn't. Age had no impact, but also, we did this in the first 3 months and it may take a little more time for effects to be seen. So we might collect some more data here down the line and see where we are. Significant difference in discharge disposition distribution was likely multifactorial, knowing that we had a higher incidence of operative intervention and an older age group could have contributed to the higher percentage of subacute rehab and hospice or ward discharges. But, frailty and baseline function are also factors that could impact that discharge disposition, but we didn't have a screening process in place for that at the time. Again, we are looking to get that going, and I think that'll provide us a lot of valuable data and help guide care going forward. Payer source is another impact that can definitely have an impact on discharge disposition and length of stay. You see here some things that I found in a lot of the literature that our geriatric trauma patients are experiencing delays in discharge, more so to insurance related delays and deferrals and not necessarily medical issues. So that's an evolving factor, but that is a reality that we need to be mindful of. In looking at complications in the trauma registry, we didn't see statistically significant differences, but there was also a very limited number of complications that were recorded or found in the data sets. So I think that made it difficult to find any statistical significance. But that higher percentage of unplanned ICU admissions on our geriatric trauma unit was something to look at. Again, older patients, more operative interventions, both factors, could have contributed to this given the limited physiologic reserves found in older patients and the stress that operative intervention can place on them. And again, baseline frailty could have had an impact here, but without this data, we had no way to assess for that. VTE was only found in that 2023 control group and the 2024 intervention group, but we know that there was a higher instance of operative intervention in both of those groups. So that kind of seemed to make sense there, since it's a known complication of operative intervention, especially in the older patient. Our hospital-acquired pressure injuries were low and fairly uniform across all 3 groups, so that's fantastic. And then inpatient falls were only found in the 2023 control group. So no real explanation identified in this data analysis, but that's great news. So happy about that. One of the complications that we did see a decrease in for our patient cohort was hospital-acquired delirium. And I think that's pretty interesting given that this was the oldest sample group and age is a known independent risk factor for delirium. Given this finding and kind of some anecdotal observations, I also decided to investigate our bedside sitter presence prior to and following our dementia-friendly education and our initiation of the unit. This orange line here was our intervention unit. And you can see prior to our training, we had a pretty high, probably the highest usage of bedside sitters out of our trauma groups. This is when we did education in this quarter. And you can see we had a big drop, but probably right about in line with where some of our other trauma units were. Following the launch of the unit, we're down below every other unit. which I think is pretty significant. I was really proud of our team. We had a decrease of 96% from the quarter prior to the close of the study period in our bedside sitter hours. And, I think that's, especially seeing we had no falls, we didn't have any adverse effects due to that, and our delirium, incidents went down. I think that's a pretty, something to be proud of. So I think that dementia-friendly training, the delirium checklists and rounding, I think helped the unit effectively manage dementia and delirium behaviors, as well as preventing it overall. So that was a pretty significant finding as well. So just kind of some implications as other folks or other institutions are looking at this and thinking about this care model. Given that we had a successful translation of the principles of a geriatric friendly environment into this unit, some of the implications for practice and education that I wanted to highlight. I think appropriate unit selection is key. Our unit had trauma surgical experience, but we have a lot of orthopedic trauma buy-in, and our hospital medicine fragility fracture team support their case managers and pharmacists and our ortho residents all kind of live in this space. So they're pretty easily accessible to us. I think having that dedicated durable medical equipment or DME for each room is also a contributing factor in supporting safe and consistent mobility. Nursing team support was necessary. And I'll be perfectly honest, there was definitely apprehension initially from the team. We said, we're going to take on the majority of the geriatric trauma patients and really focus on how we can take the best care of them. These patients do have limited physiologic reserve, more baseline cognitive deficits, and more likely to be frail. And that made them a little bit apprehensive. Those education and live Zoom sessions were used as a means to help support their practice. I know I mentioned this earlier, but that's also how we utilize those delirium checklists. They were a practice aid, not a deliverable to management. Like, here's one more thing you have to do and turn it to me. We also validated and talked through their concerns at our staff meetings. And hearing some of that, we decided to kind of flip the script, and we did a unit-wide positive promotion campaign. We had some prizes that we gave away to anyone who could bring something positive to the team about the initiative as a way to change the narrative and just to kind of change the mindset. If someone could bring up a really positive thing about what we were doing here, they would get a prize. We'd share that in the end of week note in our beginning of shift huddles. And I think, after a while that kind of caught on. And earlier this year, spring and summertime, we tend to see a little more of our younger trauma victims, not as many of our older ones. And so we were getting a little bit of a little shift in some of our patients we were taking care of. And I know one morning at huddle, the nurses said, "Where are our dementia patients? We miss them. We want them back. What is this?" I was like, "No, they're coming back. Don't worry. They'll be here. So don't never fear." But it was just such a shift from when we started to where we are now. And they've really embraced it and done a fantastic job. So I'm very proud of that. Beneficial cost implications associated with building a team that is more understanding of and comfortable managing behaviors associated with baseline cognitive decline and acute cognitive disturbances or delirium. If you look at the difference in cost of just the sitter hours alone each quarter as compared to the initial quarter prior to the education and intervention, we may have already seen a total cost savings of over $11,000. So that's something to take away as well. Just wanted to speak to some of the limitations that did exist in this study due to its retrospective nature. Potential for confounding variables was certainly there. We did attempt to control for some of this by using the two different control groups, one from the same time period, one from the year prior. The quasi-experimental nature certainly contributed to a limited ability to determine any causality, and a lack of true randomization of patients to groups. This is also just a single center study, so that limits generalizability. And I'll again mention payer source and frailty as two variables that were not considered in this study as limitations. The American College of Surgeons recognizes frailty to be more predictive about adverse outcomes than age alone, and given Kentucky's higher risk for frailty in its geriatric population, this is likely an important missing factor. But in closing, I'll again note that we were able to successfully operationalize a geriatric trauma unit at a large academic medical center here in Kentucky. Based on the data collected and analyzed, discharge disposition distribution was significantly different. We think this is likely multifactorial in nature. We saw a very important decrease in hospital-acquired delirium and bedside sitter hours. Despite having a significantly older patient population that underwent more operative interventions, and this has produced an already realized cost savings. And this is just the beginning. I think this work really showcases how a dedicated geriatric trauma unit can provide cost savings for an organization and improve the hospital experience for our geriatric trauma patients and the providers that care for them. So that is the big bulk of what I have to present. We've done a lot of work on this. This has been a big labor of love for me for several years as I've worked with these patients and these teams, and just to see everything that we've put into place has been a real privilege, and I'm really excited to see how we continue to impact our patients.
Okay.
Any questions?
Yes, Deb Campbell, she asked, I would love more information about the bone fragility work, and where could it be found?
I can try to provide you Dr. Rao, and that's RAO. She has been the lead on this from our nephrology department, and she's built a team. When we first started that work, it was really limited to her hip fractures. It's kind of where we started everything, and we ballooned out from there. It was just her. And now she's got, I think, 3 APPs with her. They've got a whole team. And then us being able to establish that clinic has been fantastic. But they are part of our nephrology department. Deb, I can try to shoot you an email and get your information just to.
Okay, thank you.
Contact.
And I think Roy can then send it out.
Yeah.
Then Victoria said, excellent study. Did you measure patient satisfaction with stay on your unit versus another? I would predict they would feel more comfortable on your unit.
Yeah, that is not something we included in this study. It was definitely an afterthought. I do know that, I didn't compare ours to other units per se, but I do know our patient experience scores as far as in the nursing category. I don't know if we're given like metrics we're meant to meet each year. We were well above our max expectations. So I know we had an impact, but didn't compare to others. So.
Okay. Shannon asked, is there a way to get information on details for the geriatric trauma unit or an email for contacting later?
Yeah, I will put my email in the chat. And yeah, feel free to contact anytime. This was just kind of something a little on the